Hey folks, welcome back to the show. As always, we have a fabulous action-packed episode for you today. My guest is going to be talking all about da bones, bone health. And I know that we talk a lot about muscles being the organ of longevity, but bones kind of pretty important when we're talking about longevity. So he's, well, we'll talk about him in a minute. Before we do that, I would love to, first of all, thank you for being here and invite you to leave a review for this podcast on whatever platform you are listening to the podcast on, because that, of course, is how we get found and reach more people. And also to check out natnitum.com. That's where you can sign up for the newsletter. You can, and actually the newsletter, there's now a new newsletter that's all devoted to peptides. So you can sign up for both lists or one list, whichever one you prefer. And also where you'll learn a bit more about the BSP community that we're building over on Mighty Networks, which is a great, it is paid, but we're keeping it reasonable. Prices will be going up next year, just so you know. And I do live Q&As in there. I have guests come in and do live Q&As. We do all kinds of cool things in that community. So if that is of interest to you at all, head on over to natnitum.com and learn a little bit more about it. Now let's talk a little bit about our guest. In this episode of the Longevity Podcast, I am joined by Dr. John Neustadt to discuss one of my favorite topics, bone health. We dive deep into the surprising truths about osteoporosis and bone density testing, revealing why traditional methods often miss the mark in predicting fractures. Dr. Neustadt shares his extensive research and clinical insights. He explains the crucial role of collagen and other proteins in bone health and discusses the controversial use of certain medications. He shares actionable tips on supplements, diet, hormone replenishment, and effective exercises to help maintain strong bones as well as reduce fracture risks. Suffice to say that this episode is packed with valuable information for anyone looking to improve their bone health and overall well-being. To learn more about Dr. Neustadt and his work, you will want to head over to his website at www.nbihealth.com. He also has a Facebook community, which is NBI Health. He has a YouTube channel, also NBI Health, as well as a Twitter channel, or X, I guess now, which under his name, John Neustadt. Everything is in the show notes. And now let's jump into the episode. Hey folks, just a quick reminder that all of the information presented in this podcast is for information purposes only. No medical advice, no diagnosing, no treatments suggested here. Before you try anything that you hear about or learn about here, make sure that you check with your medical provider. Dr. John Neustadt, welcome to the podcast. It's a pleasure to have you here to talk about one of my pet topics. I love it.
I love the topic too. So I think it's going to be a fun, good, wide-ranging discussion.
Yeah. And you have some really, I didn't know this going in, but you have some different ideas around some of the key beliefs that people have around building bones. And so I think it's going to be a good discussion. So let's start with you. Let's talk about you first. Why don't we help people to understand who you are, why you're so fascinated with bones to the point where you've written a book and done all kinds of things around this tissue in our body.
One thing that I think is important that people understand is that I love research. I love to dig into the research. I love to understand how things work and why. And when I was in my clinical practice in the mid-2000s, 2006, I started to have patients come in with osteoporosis. I never thought that I would become an expert in this topic. But patients were coming in and I was doing what I was trained to do, working with them with nutritional medicine, talking to them about medications when appropriate, making exercise recommendations, dietary supplement recommendations, and their bone density was going up. So I was happy because that's what we were tracking. And typically that's still the only thing that's treated or tracked conventionally. My mother-in-law, who's now 93, she has osteoporosis and she had it at the time. I was working with her, again, nutritional recommendations, exercise, supplementation. She had a medical doctor that she was working with and had her on Fosamax, and she was taking that, and her bone density was going up. So she was happy, her doctor was happy, I was happy, and then she tripped on a throw rug in her house and broke her hip.
Hmm.
And I thought to myself, what's wrong? Something is wrong with this picture, because by all objective measures, she should have been protected.
Mm-hmm.
And she wasn't. When I started looking at the data on osteoporosis and bone health, it shocked me to know that since the 1990s, in the research, we've known that a bone density test predicts less than half of people who will break a bone. And then in 2008, a study came out that quantified that even more, to a greater degree. And now we know that a bone density test only predicts 44% of women with osteoporosis who will break bone, and only 21% of men. And every medical association that's looked at the research has correctly concluded in their position statements that fracture risk depends on factors largely other than bone density. And there is no one approach that's applicable to every person. And yet, even still today, it's that number on the test that's being treated. Their doctors are trying to move that number on the test, but they're not treating the patient in front of them, with dangerous consequences. Because if you have osteoporosis and you fracture a hip, there's up to a 36% chance that you're going to be dead within a year. If you
Mm-hmm.
happen to survive, about half of those people never regain their pre-fracture level of mobility and pain-free lifestyle and enjoyment of the life that they had before. And a significant percentage of those people continue to need additional care just to do the activities of daily living that they can't accomplish on their own anymore, like feeding themselves, bathing themselves, shopping, driving, those sorts of things. And a scary number that I love to tell people to sort of drive this point home of how dangerous this is if you're a 45-year-old woman, your risk of an osteoporosis fracture is equal to your combined risk of breast, uterine, and ovarian cancer. And
Wow.
osteoporotic fractures cause more days in a hospital than other conditions like heart attacks, diabetes, and breast cancer. And every 30 seconds, someone somewhere in the world is fracturing because of osteoporosis. And my point with all of that is not only to shock people a little bit, and hopefully you are, because those statistics are shocking, but to understand that it's really about fractures. And that
Mm-hmm.
should be the entire emphasis of every discussion, how to evaluate every recommendation or test. How does it relate to my risk for fractures?
Yeah.
And if I change that number on a test or follow this recommendation, is it going to reduce my fracture risk?
So, what is it about the bone density test? What is the bone density test missing? Because that, I mean, there's a lot of shocking things that you've just said, right? So, we'll go at them one at a time. But the first one, which I think is the biggest elephant in the room, is what are those bone density tests that people are hanging their hats on missing, that they're less than 50% effective at predicting fracture risk?
You mentioned bone as a tissue in the
Mm-hmm.
introduction or when you started, and all tissues are complex. They're made up of more than one thing. A
Mm-hmm.
bone mineral density test only detects the quantity of minerals in your bone, calcium, magnesium, other minerals in your bone. How much is there? That doesn't tell you the quality of the bone. Bone is made up of different things. Minerals are just one component of it. The other
Mm-hmm.
major component of bone are the proteins in bone. And the major component of that provides the ultimate strength to bone is the bone collagen. But
Yeah.
in addition to collagen, there are 180 to 200 other proteins in bone. So it is made up of a lot of protein. It's a highly protein dependent tissue. And in fact, if you were to take vinegar, you take a chicken bone, soak it in vinegar for about maybe 5 days, and keep refreshing the vinegar, it's going to demineralize that bone. It's going to pull all those minerals out. What you're left with is the collagen and any other proteins that might be there, and it is indestructible. You can bend it, you can hit it against a wall, it won't break. That's the
Interesting.
strength and power of the collagen and the proteins. And if you were to do the opposite, though, and somehow remove all of the collagen and proteins from bone, and all you were left with were the minerals, it would be brittle like a column of chalk, and you could easily just break it. And so that's what the bone density test is not taking into account. It cannot detect those other components of bone health and bone strength that are even more important to the health of bone than just looking at the minerals.
That's so, and that really speaks to one of the things that I've often talked about is that we can't just keep thinking about bones as being strong and hard. We have to think about bones as being strong and flexible. Like they have to
Absolutely.
bend. If they, and I believe, and maybe now we can talk a little bit about, you know, the medications that conventional medicine has brought out for to supposedly treat osteoporosis, which my understanding is that it can actually lead to more brittle bones. It can actually create a false sense of security and a situation where the individual's left with bones that appear to be stronger, but yet it's almost like your chicken bone. It's where, you know, nobody's paid attention to, or there's a depletion of the collagen and the other proteins, and you've got all this mineral, and now you've got something that can just crumble.
There's a category of the medications called bisphosphonate medications that paradoxically, because we're trying to reduce somebody's risk for a fracture, in a very small but significant percentage of patients can actually increase their risk of fractures. They're called atypical fractures. Usually it takes a high force to break a bone. And in the research, when you start looking at the case reports that have come in and the studies, these are fractures that are occurring from just daily activities. In one report that's out there, a woman she was watering her plant, stepped down off of a step stool normally, didn't fall, didn't lose her balance, and her femur fractured. And what
Wow.
happens, unfortunately, when you get one of these fractures, when you're on a bisphosphonate, it takes longer to heal as well. So
Mm-hmm.
part of the problem with the medications, with that category of medications, is it's stopping the normal healthy deposition of bone. There are two major cells in bones involved in uh, creating and maintaining bone health. That is the osteoblasts and the osteoclasts. The osteoblasts build up new healthy bone, and the osteoclasts break down old, worn out bone in a process called bone remodeling, which we need.
Mm-hmm.
You have to have that for healthy bone. And when we're growing as babies and in our teens and into our 20s, our osteoblasts are working harder and have more activity than our osteoclasts, meaning you're building up new healthy bone. And what happens with these medications is they are poisoning the osteoclasts. So the osteoclasts aren't working anymore. So you're not getting that old worn out bone broken down for the bone remodeling, which you have to have for healthy bone. About every 10 years, your bone is completely turned over when you're healthy and you have new bone. Well, that
Mm-hmm.
stops this healthy process. And so you're
Mm.
getting the deposition of bone by the osteoblasts in odd places unnaturally, and the old worn out bone is not being broken down and recycled. So you get these weaknesses in the bone, and that's the problem with those bisphosphonate medications in terms of that side effect. They
Okay.
could also cause osteonecrosis of the jaw, as well as other categories of medications as well, meaning that if you have typically a dental procedure while you're on the medication, you get a tooth extraction, for example, your bone literally can just start to disintegrate. It's a very
Wow.
dangerous situation. Dentists often will screen for the medications. If people are on osteoporosis medications and those that increase the risk, they'll ask them to stop and take a holiday from them for a time before they will do that
Wow.
because of that risk. And the bisphosphonates, though, and any of the medications, the most important question, though, in addition to understanding the potential side effects, is how well does it reduce my fractures? Is this going to
Mm-hmm.
reduce my fracture risk? Because the research is clear that the change in bone density, all the osteoporosis medications will increase your bone density, those that are FDA approved. But not all of them will reduce your fracture risk at both your vertebral spine and your hip equally. So there are, and many of them, there's only one that if you've never had a fracture before with osteoporosis, meaning we're trying to prevent you from getting a new one, all the medications except for one have been shown to only reduce vertebral fractures in that population, not hip fractures, which are the most dangerous. If you've already
Mm-hmm.
had a fracture and you're trying to prevent another one, then you have a longer list of medications that are can be helpful at reducing fractures at both of those sites. But that's the nuanced conversation and nuanced understanding of the medications. And unfortunately, and it's just not my opinion, a study came out showing this, doctors don't understand. They're not sure how to interpret the test. They're not sure how to talk about it. They're not sure which medications to use and in which situations.
Wow. So is there a medication that actually properly addresses bone density in your opinion, or is it still just part of a solution and there's other pieces of the puzzle that need to be addressed?
So bone density is always just part of the solution because
Right.
it's a piece of a much larger puzzle, and it's important not to focus on a test result, but
Yeah.
on how we can reduce your fracture risk. And so the bone density test is just one piece of that larger puzzle. I like, in terms of the medications, if somebody is going to decide to take one, the anabolics, or that category of medication called anabolics, which includes Forteo, Prolia, or denosumab, things like that, that actually promote more osteoblast activity and aren't stopping the osteoclast activity. So they're not affecting that. And so those have excellent fracture data on them, the best fracture data, in fact, in terms of reducing fractures in secondary prevention of osteoporosis, in terms of looking both the hip, make sure you're also reducing hip fracture risk as well.
Well, because they're addressing the bone health. So anabolics. So are we talking about things that actually increase growth hormone in the body in any way? Or, I mean,
No,
anabolic means building, right?
anabolic means building.
Do they also affect muscle building? Like,
No,
do they drive anabolism,
no,
anabolic
no, no,
processes
no.
systemically, or it's specific to bone tissue?
No, that's specific. So Forteo is a recombinant parathyroid hormone medication. So that really just affects calcium deposition in the bone and the other aspects of bone health, but not muscle building of muscle, for example. The denosumab or Prolia, that is a monoclonal antibody, and that affects a different, kind of biochemical pathway within osteoblast and osteoclast activity. There's another category of medications called the sclerostin inhibitor. All of those are really just targeting bone. They're not
Okay.
affecting other hormones or aspects of people's health.
Okay. It's too bad because building muscle is also a big part of better bones, interestingly enough.
Absolutely, absolutely. And in fact, that's an important point because, as you know, you have to have muscle strength and balance to prevent falls.
Hmm.
And falls account for 95% of fractures. So anything we can do to prevent falls is necessarily going to prevent that. And importantly, though, people don't really think of bone as such a highly protein dependent tissue, but it is.
Yeah.
What we know is that consuming even just the amount of protein within the USRDA range can account for 2 to 4% of bone mineral density, because the minerals they bind to the proteins, and so you've
Hmm.
got to have enough protein to produce the collagen and for other things in the bone, and so that's really crucial. But people aren't getting enough protein as they age. As we age, the requirement for protein to maintain muscle mass and strength and to maintain healthy bone increases. So my recommendations, based on the research in the book, is to get higher than the USRDA, and people calculate
Hmm.
how much they need based on their body weight. And some recommendations even go higher. Mine's sort of the floor, but some recommendations even go higher than what I do in the book.
Yeah, no, for sure. I mean, I think it's a huge point, right? And so let's talk a bit about the collagen and the proteins, because everybody's like, and we'll get to the minerals later. But how do people increase the collagen? How do they support collagen and protein levels in their bone? Is should they be taking collagen supplements? Is bone broth enough? Like, what's the way to support those elements of bone that are so key?
I think about this issue in a similar way that I think about overall bone health. There are two sides to this puzzle. One is, what can we do to remove or reduce anything that is destroying the collagen or destroying
Hmm.
the bone or impacting the bone? And then the second thing is, what can we do to give to the body to grow new healthy bone and strengthen bone? So with respect to collagen, what we do know is chronic inflammation damages collagen and destroys collagen. Not only does it decrease how your cells, how much collagen your cells are producing, but the collagen that is there, it makes it more brittle. And so reducing that chronic stress and inflammation, both of those do the same thing. That is important for not just for bone health, but for many chronic diseases and health in general.
For sure.
And then for building things back up, we already talked about consuming enough protein. Collagen is a protein. If you're giving your body the raw materials, it's biochemically going to put the nutrients where they need to go. It's going to assemble the collagen on its own. Even all the collagen supplements out there, you're not eating just straight collagen. You're eating collagen peptides. Typically, hydrolyzed collagen is broken down strands of collagen, and there are clinical trials showing that supplementing with collagen can improve bone density, and reduce a marker called CTX. CTX is a marker that can be tested in the blood or urine that is an indicator that you have collagen breaking down. So when that's elevated, it means your collagen is breaking down. And so supplementing with collagen as a dietary supplement has been shown to reduce that CTX marker and has been shown to improve bone density. There are no fracture outcomes data with that yet, but that does exist. Some clinical trials do exist. The other thing is consuming just enough protein, like we talked about, making sure you're getting enough of those raw materials. Calculate how much protein you should be getting. If you're having a hard time consuming that much daily, then definitely supplement. I'm a believer that dietary supplements should be used as the FDA intended. That is, as a supplement to a healthy diet. Always diets first. And then you can bridge the gap with those proteins. Or if you feel like you need a little extra support, you can do a protein powder supplement, or you can do a collagen supplement. Technically collagen is not a protein supplement because it doesn't have all the essential amino acids. But you'll be getting that when you combine it with the food you're eating and all of that. So that's not really a concern of mine, but I just want to be clear, collagen is not considered a protein dietary supplement. It is a collagen peptides.
Yeah. And I mean, one of the things, and certainly with, people who are more elderly, whose, digestion might be a little bit not as efficient as it used to be, aside from using digestive enzymes to assist that, I have found, and I don't know how you feel about these, but I found that a good essential amino acid supplement sometimes can just provide the body with those building blocks of protein in a form that doesn't take up real estate in the stomach.
Right.
I mean, it doesn't replace
absolutely
eating good quality protein because you get so many other nutrients from it. But those essential amino acid supplements can actually go a long way to topping you up when you just can't get it with food, or you're not. I also find and they don't even have to be older, but people find that they might, if they're not digesting their protein properly, they start steering away from it because they're like, oh, it's too heavy. I can't, so if we can't get them to at least take digestive enzymes, then bringing in these more easily digested forms of protein can kind of fill the gap where it's lacking.
Absolutely. You and I are on the same page as that. And I would just add, though, is that if you could try and identify the underlying cause of maybe why they're not digesting their proteins well enough, or other foods, or having some gas and bloating, having acid reflux, those sorts of things, it could go a long way to helping improve their health. Let me give you a quick example. So as people age, just naturally or in general, they tend to decrease in how much stomach acid they produce. And if you have an autoimmune disease, that definitely can increase, or like an acid blocking medication. Obviously, you're suppressing your stomach acid, and stomach acid starts that process of digestion and activates some of the digestive enzymes. And so looking at, are you having low acid production, or do you have an H. pylori infection that can cause acid reflux? Do you have atrophic gastritis, where your stomach tissue is sort of thinning, there's and not functioning, maybe not producing as much of the stomach, the enzymes that your body needs. And there are ways to address that from an integrative, naturopathic, perspective to promote and improve your digestion. So if you can get to the underlying cause, just like we're talking about with bones, if we can get to the underlying cause of why people are losing bone and stop that, you're going to go a long way to helping reverse it.
Yeah, no, I love that. I mean, I think that, digestion is that place to start. It's a little bit like you mentioned inflammation and chronic stress. Like these are these underlying conditions that underpin pretty much every chronic disease that's out there,
So true.
um,
Yeah.
including bone density issues. Digestion is another underlying root cause, if we even want to call it that, again, of a myriad of issues down the road. And it kind of speaks to, I'm sure you've heard this before, I'm sure a lot of listeners have heard that your body can only use what you've been able to break down and assimilate. And
Yeah.
if the digestion's not there to break down your components, even minerals in the absence of appropriate stomach acid don't get chelated, can't get absorbed, and can't get used the way that you need them.
Depends on the mineral, but yes,
Yeah.
most that is correct. But not all forms and dietary supplements have that challenge. And I know we're going to talk about supplements in a
Yeah.
bit, but I do want to say also with the digestion, making sure also there's not a dysbiosis, some bacterial overgrowth or yeast overgrowth or small intestinal bacterial overgrowth. The SIBO, those also are important because those can be issues in terms of digestion. And I just would like to mention, if it's okay with you, medications, not the
Yeah.
osteoporosis medications, but medications in general. It is
Mm-hmm.
a major concern of mine, the medications that people are taking and how they are destroying bones, and
Yeah.
doctors aren't aware that they're causing this problem. So I mentioned the acid blocking medications, specifically the proton pump inhibitors, that
Yeah.
category of medications. The US FDA sent out a warning letter in 2010. So this is not new,
Wow.
telling
Yeah.
doctors of the dangers of these medications for bones, that they create osteoporosis and increase fracture risk. It's a similar story with most medications. The higher the dose and the longer somebody takes them, the more dangerous it is. But those medications were never approved for long-term use.
Yeah. The
And
6 weeks, right? Wasn't it a
yeah,
6 week window
correct.
originally?
But yet people are taking them for years. And now we know that even after 1 year of taking it, your risk for fracture is increasing. And the most dangerous type, hip fracture, after 4 years, there's about a 60% increased risk for hip fractures on that medication.
Yeah.
Now, 50% of those medications are prescribed for just one indication, which is acid reflux. You can do some dietary changes, and they're some of the most common triggers for acid reflux are specific foods like raw onions and garlic and tomatoes and coffee and chocolate and citrus and spicy foods. And with dietary modifications, you can oftentimes maybe go off the medication or decrease it because you're addressing the GERD. H. pylori infection can cause acid reflux. But one of the tragedies of this story is not just that the doctors are unwittingly prescribing medications that increase people's fracture risk and death, is that when they go and they see the osteoporosis develop, there's no data showing which type of osteoporosis medication is the safest and most effective, given this new problem that's relatively recent. It's not postmenopausal osteoporosis, which is
Mm-hmm.
caused by the drop in estrogen, and that's what the vast majority of the clinical trials of the medications are on. And the doctors just say, well, it worked for postmenopausal osteoporosis, so we're going to use it in this other situation as well, despite the fact that the mechanism of actions are very different. What they discovered was that when somebody takes a proton pump inhibitor with a Fosamax or an oral bisphosphonate medication, their risk for fractures was actually higher than people who just took the proton pump inhibitor without the osteoporosis medications. They were
Wow.
actually making their fracture risk even worse. And people who
Crazy.
took the proton pump inhibitors just for acid reflux, their risk for fractures is greater than people who are taking the proton pump inhibitor for other indications. Right?
Yeah.
Anything that you can address in terms of underlying issues to get off or decrease the medications, or see about maybe switching to a safer one. The histamine 2 receptor antagonists like Tagamet appear to be safer. But these are
There'll be
discussions
another
your doctors aren't
consequence.
aware
Yeah.
of and aren't educated to have, which is all in my book. And resources, that you can find on my website and online. Another medication I'm extremely concerned about are the antidepressant medications,
Mm-hmm.
specifically anyone that artificially raises serotonin or increases serotonin. The Prozac, Lexapro, Effexor, those types of medications. What we know is that there are serotonin receptors on bone. Bone is a complex tissue, right? It's not just minerals, as we discussed, but there are melatonin receptors on bone. There are serotonin receptors on bone, lots of different receptors on bone. 95% of serotonin is not produced in your brain. People, I think, understand serotonin as the happy chemical that helps improve their mood.
Mm-hmm.
95% of it is produced in your gut.
Yeah.
And it doesn't get into the brain. It circulates throughout your body, but doesn't cross that blood-brain barrier. What it does do is it can attach to serotonin receptors in the bone. So when you're artificially increasing that serotonin, what you're doing is you're disrupting that balance, that delicate balance of osteoblast and osteoclast activity, the bone building and bone breakdown cells, in the favor of breaking down more bone. So multiple studies have been done on this now, and we know that people taking these medications for 1 to 5 years, for every 19 people taking this medication, we will expect one to break a bone.
Wow. That's crazy.
It is crazy.
That's huge. I mean, I had not heard about the SSRI connection. Of course, the other thing with the PPIs is, aside from bone, is increased risk of cardiovascular disease over time as well.
And dementia.
And dementia. I
Associated with
mean,
that
so
and
much.
yeah.
It's, yeah. And I kind of think of PPIs as pacifiers that you might give to a toddler. Except that it's more appropriate to give a pacifier to a toddler because they'll outgrow it eventually, even though they might kick and scream giving it up at some point. But so often, and I know people like this, they don't want to make those changes to their diet.
Right.
And therefore, they know that if they take a PPI and get one of those funky beds that allows them to sleep on a tilt up, they will be able to manage or mitigate that heartburn reflux so that they can sort of sleep in their passed out state, and just keep eating and drinking at will. And it's, I mean, I don't want to go too far down that rabbit hole, but this is a call out to listeners to say there's no free lunch, and if you have a condition that can be addressed by diet and lifestyle changes, if your goal is to live a longer, healthier life, you owe it to yourself to really think about the choices that you're making and what outcome you're looking for.
Right. And when you suppress a normal, healthy physiological function that our body needs, we see that with the side effects of the bisphosphonate medications I talked about, suppressing that osteoclast activity, poisoning those osteoclasts, suppressing the healthy acid production from your stomach with acid blocking medications. Those are there for a reason. They are helping us. And when you actually are suppressing those with medications, although look, in some cases they're absolutely necessary. But
for short term they are.
But research has even shown, they've done research in looking at hospitalized patients who are taking acid blocking medications, and it showed that the majority of people on those medications were not even on them for an indication that was warranted. They shouldn't have been on them. They shouldn't have been prescribed them
in the first place.
First place.
Yeah. Okay, so we now know that if you've been on a PPI for a long time, think about talking to your doctor or seeing a practitioner who can support you in coming off them if what you're interested in is this long-term play. The SSRIs, again, very, it's complex and it's more of a process, but thinking about what people can do to mitigate that impact on other tissues, including the bone. What we haven't shockingly talked about yet is postmenopausal bone loss, or I guess bone loss or compromised bone health, which is, it's interesting to me that, how you talked about, depending on what's driving the issue with the bone is going to dictate the medication and possibly I guess the intervention is always going to come down to the nutrition, the exercise, and managing inflammation, the gut microbiome, digestion, all of those things. But there's something, the loss of estrogen in women as they go through menopause is a massive driver. And so maybe let's talk about that form of osteoporosis, if I can refer it to it that way, and what you see are as the best interventions there. Like, is it bioidentical hormone therapy, which, I mean, I'm a big fan of for most people, as long as they're seeing the right practitioner and having it managed properly. But is there other things that people should be considering as well?
I'm so glad you brought this up, because postmenopausal osteoporosis is the number one category of
Mm-hmm.
osteoporosis. So about 80% of cases of osteoporosis are in women, about 20% in men. And it's a disease or a condition where the risk increases as people get older, just like all chronic diseases, really.
Sure.
But with this, what we see when a woman enters menopause, goes into perimenopause, and estrogen begins to drop, and for the 10 years after, that's the time in her life where you have the fastest rate of bone loss, because
Mm-hmm.
estrogen is anabolic. We mentioned that word before. It helps build bone. It's also anti-inflammatory, has many roles in the body. A lot of people don't know it's estrogen in men as well that
Yeah.
maintains bone. So testosterone is converted in the body to estradiol, and it's the estradiol in both men and women that is responsible for helping to maintain healthy bones and improve bone health. So I am a huge fan of hormone replacement therapy. I do like the recommendation as soon as a woman starts to think she's going through perimenopause. And by the way, by the time she's getting symptoms, you've already got the hormones have been dropping for a while. So this
Yeah.
is something just when you wake up and suddenly you've got night sweats, or you start to realize your cycle is getting more and more irregular. Your hormone levels have already been changing for a while and fluctuating. So I like to get
Mm-hmm.
a baseline of FSH, and LH, and estradiol, and progesterone, and pregnenolone, and other hormones as well, and other tests, just to see where people are at, and a baseline bone density test.
Yeah.
Want that baseline as you go through perimenopause, so we know where we're at and where we're dealing with. And then you can track that with repeat testing. The recommendation is about every 18 to 24 months with bone density tests. But with respect to hormone replacement therapy, the research is clear that can reduce fractures by about 40%, and it can reduce hip fractures, again, the most dangerous type of fractures, by about 28%, which is great. What we're doing is just taking your hormones and getting them back into the normal range. And so many things get better. It also reduces the risk for diabetes, cardiovascular disease, dementia, all those things that nobody wants.
No. Yeah. I mean, those are preventable diseases of aging, and for the most part. And the whole hormone replenishment, as it were, this was a term that was used by a previous guest, which I just love, right? It's because hormone replacement sounds very, I don't know, somehow it sounds very hard.
Mm,
Whereas hormone replenishment basically says, look, we're just bringing something back that we had.
I like that.
And right, and in
Yeah.
an appropriate way. And it doesn't mean we want the hormones of a 20-year-old. What we want is to hold that hormone level so that we can continue to function and operate in the best way possible for as long as possible. That's our whole, picture of longevity and health span, as it were. So for women though who don't use hormone replacement, is there another path? Or, I mean, it seems to me that the hormone replenishment is your most foundational way to ensure bone health, and all of the other things you talk about with the brain and the muscle, like all the skin, libido, all the things that we
Right.
know estrogen is important for. But is there another path? Because, there'll be listeners of this podcast who maybe went through menopause 10 years ago and now are waking up and saying, okay, wait a minute, do I need to be thinking about this hormone replenishment? Is it too late for me? Or is there another way that I can do this?
So the data show right now, we only have data to women up to about 60 years old taking it, is that when you start hormone replacement around perimenopause, and continue to use it, that it can maintain and actually improve bone density and reduce fractures. I don't see why it wouldn't work later, because our
Mhm.
body is primed biochemically. We're primed. It's primed to do what naturally it wants to do. It's like I see a hormone deficiency just like I see nutritional deficiency. And the analogy I like is a gas in a tank, in a car
Yeah.
tank. once, if you're out of gas, it's not going to run. But as soon as you put the gas in, it turns on and it goes. The body is primed. Once you give that hormone, once you give that nutrient that the biochemistry naturally knows how to use, things just work better. So I don't understand why, frankly, from even a physiologically, conceptually, why it wouldn't work if you start later. And I'm an advocate for people asking for it and tracking, again, with bone density tests. But it's just, again, it's one piece of a larger puzzle.
Mm-hmm. Yeah, no, I agree. I do think that, if you start 10 years after menopause, my understanding is that you have to monitor people a little more closely because there might be a slight increase in cardiovascular issues as that transition of bringing those hormones back happens. But I mean, generally speaking, if you're working with a knowledgeable practitioner, they're going to be able to help to mitigate and manage and watch that for you. So, and you might do the hormone therapy a little differently. But I do know doctors, and I've spoken to doctors on this podcast who wouldn't have no issues, to your point, with starting a 70-year-old or even an 80-year-old on some degree of hormone replacement to manage a lot of the conditions that they're suffering with that they don't need to be.
There are a couple of issues with hormone replacement therapy that are important to understand. And this overlaps with any medication, which is you want to do the lowest possible dose for the greatest benefit, right?
Yeah.
So you're going to start low anyway.
Mm-hmm.
And it has to be monitored, even in perimenopause. You've got to be getting those repeat blood tests done. You've got to be tracking symptoms and monitoring that so you can get to that optimal dose and cycle of between the estrogen and the progesterone, throughout the month. And also, though, the route of administration or how
Mm-hmm.
you're taking it has implications on it and its benefits and its safety, whether it's a pill or a cream or a pellet. Those are all different just considerations that a knowledgeable doctor in this field will take into account and can have those conversations with you about.
Yeah, I love that. Okay. We had a short conversation. Well, not that short, but we had a short conversation before the podcast. And I mentioned a bunch of the different components of supplementation that people talk about and take. And you smiled and said, "Oh, this is going to be good," because I have different views on these things than a lot of people. So different views is what we're all about, right? This is where we grow and we learn, is seeing different perspectives. And let's start with, I think about it as the elephant in the room a little bit, and it's calcium, because everybody talks about calcium, calcium, calcium for strong bones. There's a huge conversation around calcium, yes, and we also need other players to be present in the right amount so that the calcium that you take ends up where you want it and not possibly in a place where you don't want it. So, we talk about plaque inside of arteries and inside of blood vessels. A component of that plaque can be calcium. A lot of people will talk about, yes, but plaque's not going to form in the first place if you didn't have an injury to that endothelium to begin with and you don't have a bunch of inflammation. But nevertheless, we know that calcium can be a huge friend. And, just like any friend can go off the rails sometimes, maybe, calcium can work against us. So let's talk about calcium.
Yeah, it's a great topic. It's a big topic, and there's a lot to unpack in what you just said. So let me take a step back and for a moment and just frame this part of our conversation around how I view dietary supplements, how I evaluate whether people should take them or not when it comes to bone health. So as I said earlier, the most important or the most dangerous thing with this condition is breaking a bone, fracture. So I asked my question, which nutrients out there have been shown to reduce fractures, not just improve bone density, but actually improve fractures? Yeah. Now, there are only 4 that have been done that. And you can have people and a lot of companies say, well, our bone density is improved with our product, or the bone density is improved with this nutrient, in this study. But that's not clinically what we're really afraid of. And that's not what patients should be most afraid of. They should be most afraid of the outcome. Right. Because there is not a great correlation between bone density and fractures. So calcium and vitamin D are 2 of the 4 nutrients that have been shown in studies to reduce fracture risk. And I say them together because people really need to get adequate amounts of each. They're talked about, they're typically supplemented together. The studies show that when you use them in combination and have adequate amounts of both, that's when you get the benefits. So with calcium, as with all nutrients, it's a question of dose. What is it potentially an effective dose and a safe dose? Similarly with medications. So with the safety of calcium, the current recommendation or the current position statement of the American College for Preventive Cardiology and the Bone Health and Osteoporosis Foundation is that consuming calcium up to the tolerable upper limit set by the National Academies of Medicine is safe. And that limit is 2,000 to 2,500 milligrams of calcium per day. So up to that, it's considered safe. Now, there's a big, important piece to this that people should need to understand. When they talk about consuming or getting a nutrient or the USRDA, that's from all sources, both diet and dietary supplements. The current USRDA for calcium in women is 1,200 milligrams per day and 1,000 milligrams per day in men. There's no indication that getting more than 1,200 milligrams per day is better for bones. And as I already mentioned, you start get to that tolerable upper limit and you start to get into this danger zone. With respect to calcium, the average American woman consumes about 800 milligrams of calcium in her diet. And if you can get the calcium from diet and any of the nutrients from diet alone, that's in what you should do. That's what all the recommendations say. Start with diet. But a lot of people aren't getting that amount with diet. And so perhaps, supplementing with 400 milligrams of calcium is appropriate and has been shown to be safe. But you may not need calcium. It really just depends. And I recommend people track their diet, always try to improve their diet, following a plant forward Mediterranean dietary pattern with ample amounts of protein. That's been shown to be associated with a 20% reduction of osteoporosis risk and a 21% reduction of hip fracture risk. So doing that and supplementing with the calcium when needed.
Alone?
No, with vitamin D.
Okay. What about vitamin K2?
Great question. I asked the same question that I always ask. Hasn't been shown to not just improve bone density, but reduce fractures. Now, vitamin K2 is a category of nutrients. So it's not just one form. There are different forms of vitamin K2. The two that you find in dietary supplements are MK4 and MK7.
Yeah.
And they are different. They're not the same chemical. And we know in biochemistry and in nutrition, if you change one carbon atom, you can get overlapping activities, but you also get very different activities as well. And we see that with MK4 and MK7. So let's start with MK7. MK7, if you look at the clinical trials on MK7, it has never been shown to improve bone density. It's only been shown to slow down how fast somebody loses bone density. And in one study, they actually showed, and they were using different doses. Or different studies have used different doses. So they've looked for the optimal dosing, that the rate of bone loss of the hip was faster in the women who took the MK7 compared to those who didn't.
Really?
And so with respect to fractures, similarly, there are no studies that show that MK7 reduces fracture risk in people with osteoporosis. In contrast, MK4, there are over 25 clinical trials. Repeatedly, it shows to stop bone loss and reverse it, as indicated by a bone density test. It improves bone density. But more importantly, it's been shown repeatedly in different clinical trials to maintain strong bones. And the best indicator of whether your bones are strong is whether you break one. And it's been shown to maintain strong bones as indicated by over 70% fewer fractures in clinical trials. This has been studied for decades. It's been approved by the Ministry of Health in Japan since 1996 for bone health in the dose of 45 milligrams per day. Typically, you see microgram doses.
It's actually huge. Yeah.
Right. 45 milligrams per day is the dose that is shown to be effective for bone health.
Wow. And
And not
so,
just in postmenopausal people, postmenopausal bone loss, but there are clinical trials using the MK4 in that dose in people with chronic kidney disease on dialysis, shown to be
right.
people with bone loss from prednisone, people from bone loss on an androgen deprivation therapy drug like Leuprolide, um, people who have disuse from stroke,
Hmm.
osteoporosis because of that. So it's been extensively studied, not just for its efficacy, but also for its safety. And is in addition, it's been shown to promote healthy cellular function in people with cancer. MK7 has
Wow.
not. They're up to phase 2 clinical trials with MK4 using 45 milligrams up to 135 milligrams per day, both orally and intravenously, for people with acute myeloid leukemia, myelodysplastic syndrome, liver cancer, and there's one case report with acute promyelocytic leukemia, with very positive outcomes.
Wow. That's amazing. So that's MK4. And so in those studies where they look at MK4 and bone, are those studies also looking at D3 and calcium as well? Because my understanding is they work together, right?
They do.
It's a team.
It
This is a
is.
team sport. Building bone is a team sport. As you said earlier, we've got to talk about collagen, we got to talk protein, we got to talk minerals. Therefore, it's going to take a team to address all of these things.
Correct. So the MK4 in the clinical trials was used by itself. It was used in combination with vitamin D, and it was used in combination with vitamin D and calcium. What
Okay.
the clinical trials show is that MK4 plus vitamin D is more beneficial, has greater benefits than MK4 by itself. Not everybody needs, again, the calcium component.
Right.
It depends on, again, are you getting enough?
Yeah. Yeah. No, that's really interesting. Okay. So what about magnesium? What about magnesium and all this?
I love
What's its role?
magnesium.
I mean,
I
look,
love
magnesium is you almost can't go wrong, right?
I
But
love magnesium. And there are lots of reasons to supplement with magnesium. Bone health, if you're looking at fractures as the outcome and bone strength as the ultimate outcome, bone health is just not on that list for me. I
okay.
like a very targeted approach. I mean, when we can get in clinical trials a 70% and greater reduction in fractures, that's incredible.
Yeah, it's massive.
Right. And not everybody, again, get your magnesium from diet, or magnesium is used for many things in the body. Maybe you do want to supplement,
Yeah.
but I'm talking, where are you going to spend your money to get the clinical trial doses of the nutrients in the combinations shown to work? Go spend your money on the magnesium if you think you just need it for bone health, on some really great vegetables,
Yeah.
and feed your body in that way.
Yeah.
Because the research, look, there is an association with low intracellular magnesium and osteoporosis. There's one clinical trial from the 1990s that gave magnesium and it improved bone density, but there's no fracture outcome data with it. And when you look at epidemiological research, the last time I looked at this data, at least, showed that there was not an association between magnesium consumption in food and fractures.
Right.
So for me, all of that is compelling enough for me to say, look, you're taking a multivitamin and mineral supplement. There should be some magnesium in there in a good absorbable form. But if we're just talking about a very focused protocol on bone health, it was never used in any of the clinical trials that showed more than 70% reduction in fractures and improved bone density.
Hmm. I mean, it would be interesting to know if those people happened to not be deficient in magnesium, which they may or may not have looked at in that trial. So I think that magnesium, I mean, in my opinion, magnesium is so critical to so many different pieces of the puzzle in the body, in addition to having strong bones that aren't going to break on you. And it's, so many people seem to be deficient in it either because their diet's not optimal or whatever the case may be. There's kind of an argument for most people supplementing with good form magnesium anyway. But I think that's an interesting point because definitely when I went to nutrition school, one of the things they taught us very vehemently is that you want to take calcium and magnesium together, because they work really well together, because the magnesium
Yeah.
helps the calcium not. I think the story at that time was
Yeah.
that the magnesium helps the calcium to kind of stay in solute, not precipitate out or something. I actually
I,
don't fully remember the exact
yeah.
reason now that
I,
I'm
I'm,
now that
I'm,
I'm trying to pull it off the shelf. I'm like, oh wait, what did they say? But the
well,
but
and I'm chuckling here because I get this all the time.
mhm,
My products don't have magnesium in them,
mhm,
and why not? Or people say you have to have magnesium to absorb the calcium, or magnesium has to be in the supplement.
mhm,
And I ask people, send me a citation. I've heard this for decades, and I
mhm,
comb the medical research. Show me a study that shows and concludes what you're claiming. It has become
mhm,
a legend out there that you have to take calcium and magnesium together. I have
mhm,
never seen one study that shows that. And also, what you're talking about in terms of absorption.
mhm,
First of all, that's a pharmacokinetic study. So pharmacokinetics or a bioavailability study. Uh,
mhm,
so bioavailability is how well does something absorb, and then pharmacokinetics is once it's in your body, what do you do with it? How
mhm,
does it stay in your body? When do you eliminate it with your body, and all of that? Those are not clinical. That's like saying I'm going to make a recommendation based on that and not based on fractures. That has nothing to do with whether it's actually helping improve the person's health if something's more bioavailable than another. So for me, that's an important point, because I hear this with MK7 a lot. People say, well,
mhm.
MK7 is absorbed better, and MK7 has a longer half-life, so it's better than MK4, and companies are marketing that. And there's one study that looked at the absorption of MK4 and MK7. And first of all, they didn't give the clinical dose of MK4. They gave microgram doses. We
Mhm.
know it's absorbed because it's approved in Japan, and they did all the pharmacokinetic pharmacology studies on it. And there are human studies looking at the absorption. But they look at that and they say, well, MK7 is better absorbed because there's a higher blood level based on this one study. Well, even if that were true, that has nothing to do, that doesn't necessarily have a bearing on whether or not clinically it's helping you.
Mhm.
And I mentioned the clinical trials before. MK7 has never been shown to improve bone density or reduce fractures.
Yeah.
So just because something's absorbed, or just because it hangs out in the body longer, which it's questionable even if that happens with the different forms of with MK7 specifically, that may not and is not the clinically most relevant thing that people should be concerned about. And so I say that with magnesium and calcium as a long way of saying, if you're hearing this out there and you've been told this and you have a citation that shows you have to have magnesium to improve improve your bone density, it has to be there as a dietary supplement, but more importantly, that it reduces fractures, please let me know.
Yeah,
Because
well, you're definitely looking at it through a very specific lens. So I think we can agree that magnesium is important. It may not have been shown to decrease fractures, so it's not in that playhouse. There's a lot of other good reasons to make sure we're getting enough
absolutely.
magnesium.
Absolutely.
So,
And about half of the US population don't consume the inadequate daily amount of
yeah.
calcium or magnesium, I'm sorry, in their diet. And yes, there are definitely arguments to supplement. And I'm a huge fan. I'm going to make sure it's
Yeah,
clear.
yeah,
I'm a
yeah.
huge fan of supplementing
It just
with
doesn't stop people
magnesium.
from breaking bones. Particular, or it hasn't been
Well,
shown.
it may,
Yeah,
the absence of data doesn't necessarily mean the absence of benefit.
right.
It may,
Right.
but the data is not strong enough for me to be recommending that specifically for bone health.
For
Now,
this
I'd rather
post.
have them. Yeah.
Got
I
it.
mean, there are lots of other reasons to take magnesium,
Yeah.
but there are lots of reasons to take many things. Like, where do you draw the line of how many supplements you're taking? What dosages do you take? How much money do you spend on them?
Yeah.
So I
I
want
think,
clinical
yeah.
evidence that they work.
Yeah, I think those are personal decisions, right? And they vary
Yeah.
from person to person. So, and they may change over time also. Like our
Absolutely.
needs change over time based on our lifestyle, based on our age, based on our life stage. So, okay. So, what are the other? I mean, people talk about a lot of other things when it comes to bones. They talk about boron, they talk about silica. Do you want to kind of touch on those a little bit before we run out of time? Because
Yeah. So neither of those have been shown to reduce fractures or improve bone density in human clinical trials. The boron, in fact, was you get increased calcium. There was an animal study where you saw increased calcium excretion when there was not enough magnesium there, and they were deficient in boron. But as soon as they had enough boron, that wasn't the case. So that doesn't necessarily mean that you're getting osteoporosis, excretion meaning through the urine. Right.
right,
So that companies and people are hanging their hats on those studies, but there are no data showing that supplementing with boron improves bone density or reduces fractures. Again, as I mentioned, there are only 4 nutrients that have been shown to do that. So it's
right.
calcium and vitamin D, MK4, 45 milligrams per day in divided doses, and strontium. And I am not a fan of strontium.
You're not. All right, let's talk about that.
So strontium is a mineral and it incorporates into bone, and it has been approved in Europe. It was approved as a drug called proteolus in the form of strontium ranelate. In dietary supplements, it comes in the form of strontium citrate. There were 6 large clinical trials on strontium ranelate in Europe for postmenopausal osteoporosis. Of those 6 clinical trials, 5 of them showed that it prevented vertebral fractures, but not hip fractures. Only one of the clinical trials showed a significant reduction in hip fractures. So for me, it's questionable whether it actually reduces fractures at both of those sites. The reduction in fractures was about the same magnitude that you would get with an oral bisphosphonate like Fosamax, about 45%. In the US, it's available as strontium citrate as a dietary supplement. There are no clinical trials on strontium citrate looking at effectiveness or safety. Safety is one of the big concerns for me when it comes to strontium, because with respect to strontium ranelate, it was removed from the market for a while because what they discovered is for every fracture that was being prevented, it was creating blood clots that can cause strokes, pulmonary embolism, and heart attacks.
Wow.
Right.
Okay.
So
So
is that
pick your poison.
is that the ranelate portion? So minerals have to be they're connected
Related.
to a carrier molecule,
Mm-hmm.
typically a protein or an organic acid. So ranelate is a protein. Is it the ranelate that was causing it? Is it the strontium that was causing it? We don't know. So the strontium citrate may be safe. It may be safer, but we just have no data on it.
How does
And
strontium occur in nature? Sorry
so
to
it's in
cut
the
in.
soil, so it can
No, I
accumulate.
understand that, but how does it show up? Does it show up bound to citrate? Does it show up bound to ranelate? Like, what's the how would it be?
Ranelate is synthetic. So ranelate
Yeah.
does not
So how would
exist in
strontium
nature.
show up in the soil?
So typically in the soil, I don't know if you're looking in the soil,
Mm-hmm.
but then when it's in plants, I mean, typically, I don't know what the form is in plants per se, but
Yeah.
it's definitely not in the dosages that people are consuming it in a dietary supplement. So
Interesting.
um,
Okay.
if you're taking it, however, if you decide to take the strontium, it does improve your bone density because it's a mineral, so it
Mm-hmm.
incorporates into the bone. A bone density test is an X-ray, and it detects the bone density by having the x-ray bounce off the minerals in the bone,
Right.
and then the machine detects that and does its mathematical magic and spits out the results. Well, because strontium is heavier than calcium, it changes that x-ray, how that x-ray reflects or bounces off the bone, called the refractive index, that angle that is created. And so if you're not in a country like Europe, where it's approved as a medication, where they can make that adjustment to the machine, the bone density test result you're getting is false.
Oh, is
It,
it overrepresented? Is the
yes.
strontium? Yeah.
Yes. And although bone density tests have their limitations, as we've talked about, I think it's important to get an accurate test result.
Mm-hmm.
So
Mm-hmm.
for all those reasons, safety concerns, interfering with bone density test results, lack of potential efficacy when it comes to both hip and vertebral fractures. I'm just not a fan of strontium when we can do much better with something that has a proven safety track record, has such incredible bone density and fracture data on it, which is the
Yeah.
MK4 calcium and vitamin D.
Yeah, that's really interesting. It's interesting about the strontium, though, because you do wonder if it was provided to the body in the form that it occurs in nature with the, in the presence of vitamin D, adequate D, calcium,
Yep.
and MK4, would it move the needle? And it's funny because it's getting into those little finer details that's really hard to find the research because it's so, it's all different. It's kind of different universes. And now trying to bring them together, it would be interesting to look at those, kind of nuances in the data.
That would be a great clinical trial.
Yeah. I think you should do that sometime. Okay. Is there anything else that we're missing in this world of supplementation? And what's your, you in clinical practice, what is it that you've seen really move the needle for your clients, your patients, when it comes to the outcome we've been talking about today? So it's not about a reading on a test. And I'm assuming when you're talking about bone density, are you talking about a DEXA scan or are you talking about a different DEXA?
Yes, bone density. Yeah.
Okay, so what have you seen move the needle for your patients? What's the secret? What's the magic?
Yep.
Sauce?
Magic sauce. Yep.
Yeah.
So since we're already talking about supplementation, let me mention that because we were just talking about that. So I'll sort of close the loop on that.
Yeah.
When I was in clinical practice, I couldn't find the dose and combination of nutrients shown in clinical trials to work in existing products that I needed to help my patients, specifically started with bone health. Yeah. So I created a company, Nutritional Biochemistry or MBI, to manufacture and create those solutions that I needed. 17 years later of it's called Osteo-K, products has increased to meet people's more unique needs for how much calcium they may need as a dietary supplement. But my first line when it comes to dietary supplements is one of those Osteo-K products. They all have the 45 milligrams of MK4 per day, 2,000 IUs of vitamin D, which is different amounts of calcium, all the way down to the latest iteration, which is a product called Osteo MK4 that has no calcium. It's calcium free. Osteo-K Minis is 400 milligrams of calcium per day, and the original Osteo-K is a full 1,000 milligrams of calcium per day. Again, both still with the clinical trial doses of the MK4 plus D3, to the point where in terms of the quality and the research, that those products are guaranteed, meaning that we guarantee that within 6 months of starting them, your bone density will stabilize or improve. But more importantly, it'll maintain strong bones. So if people break a bone while they're taking those products, we will refund their money for all qualifying purchases between their two bone density tests. So that's my first line when it comes to supplementation. The second line then is supplementing with collagen, type 1 collagen, like my NBI collagen powder that I created, but there are other products out there on the market as well. And so if they want to be a little more aggressive, making sure that if they think they need a good one. But in terms of specifically just bone health, it's very simple. It's those products, and that's it. In terms of what moves the needle, that is definitely part of a larger plan. Identifying and removing any causes that may be there. So we talked about the medications, addressing that. If they have underlying other diseases like a gastrointestinal disease, chronic inflammation, irritable bowel syndrome, things that we know cause bone loss, trying to address that as well clinically. And then in terms of rebuilding bone strength and making bones stronger, diet and lifestyle, always part of it. That Mediterranean dietary pattern that I mentioned, that plant forward whole foods diet with good sources of lean protein and getting enough protein, ample protein, as we talked about as well, crucial. And then exercise, moving your body. Now people, lifting weights is great. I think it's important to have some resistance exercise. You don't have to go into a gym to do that, though. Not everybody wants to go actually lift barbells or do bicep curls or that sort of thing. Even just body weight exercise can be very helpful. But when it comes to just looking at fractures, and there are lots of options in looking at osteoporosis and looking at falls, looking at all-cause mortality, that's death from any cause. The research is clear. There are many lower impact or many different exercises people can do, and I like to tailor it to what interests them. just walking 7,000 to 7,500 steps a day is associated with a 50 to 70% reduction in all-cause mortality. Gardening can be phenomenal. There are exercises with osteoporosis that you shouldn't do. So making sure you're working with somebody who's well educated in this area. I was just talking with somebody yesterday who was doing yoga and did the pigeon pose and fractured her hip. So there's certain poses in yoga that should be totally avoided, and ways that where you should modify exercise, even in a gym, to make sure that you're safe. So exercise is part of that. Sleep. I think that's an under-recognized risk for osteoporosis. So the researching an average less than 6 hours a night, you're at an increased risk for osteoporosis. You get faster bone loss, and there's an association with osteoporosis, as well as hypertension and diabetes and heart attacks, right? So just sleep is for so many things.
Yeah.
One thing that's in my book as a chapter as well, in terms of walking people through creating their own bone health program that makes sense for them, is connection and community. That's not talked about anywhere where I've ever seen this topic. But the research is clear. If you have a healthy social network, which really, by the way, is only having 3 people in your life that you call and do things with, they've looked at how many people do you actually need to have. Is it 1, 3, 5, 7? Well, it looks like 3. Beyond that, you're not getting additional benefits. Now, of course, it's great to have more connections and more friends, but even just having 3 is phenomenal. It shows that if you do break a hip, people who fracture with osteoporosis recover faster, and they recover better if they have an active social network, and they live longer. There's a reduction in all-cause mortality. So that's important as well. And that's all part of the discussions that I have with people, as well as the medications, as well as the hormone replacement therapy, all of those things that we discussed.
Yeah, no, I love that. I mean, it's interesting on the weightlifting because there's definitely a big narrative about lifting heavy stuff. And I think that, heavy is defined by you. My heavy is going to be different than your heavy, is going to be different than what's heavy to my mom. But I think it's about challenging the body so that there's a signal to build and maintain muscle, to build and maintain bone. And so, I haven't personally looked at the research, but I know that, there's entire businesses that are built around this concept that, combined with all of the factors that you just talked about, challenging those tissues is really going to be a big piece of the puzzle in getting the body, in keeping the body producing materials that it's like, oh, well, we need this because we need to be able to meet these challenges. But I have one more last piece of equipment to run by you, and that's the vibration plates, because there's if we look at the power plate, which is an expensive piece of equipment, you almost want to find a clinic or a gym that has one, so you don't have to spend, I don't know if it's what the latest, it's $2,000 or $2,500 to get your own, which if you have the resources to do it, great. But there's this whole industry of vibration plates, but yet there's really only one, the power plate, that seems to have the data that says that it seems to be beneficial for building bones. Have you looked into that at all yourself?
I have. So OsteoStrong, and you and I talked about OsteoStrong before, is a franchise type of model. They've got a different, around the U.S. at least, different brick and mortar stores where people go in, and it's resistance exercise on a vibrational plate. And there are studies using vibrational plates and showing an improvement in bone density. And I think that's great. And I actually talked to one of the local franchise owners. I said, can you please give me the studies on your technology? What are the outcomes? Well, they've looked at only bone density. They don't have any fracture reduction on it. So there are instances where we don't have fractures as an outcome in the clinical trials. So for me, I want to look at the next best thing. Okay, well, at the very least, has it been shown to improve bone density? And does it make sense, intellectually, at least to me, that yes, it probably also then, kind of goes to that next important step where it will likely reduce fractures as well. And I believe the vibrational plates do, because it also improves balance.
Yeah.
And so, as I said, 95% of fractures occur because somebody falls. So I think it's a great technology. And I think it's definitely an option for people.
Yeah. I mean, I'll give you an N of 1 on the OsteoStrong. So so my understanding is there's different modalities in there. They have very specific machines that have been designed to challenge the bone, and then they have the power plate on separate from it.
Yep.
OsteoStrong, I think personally saved my mother's life, because this was a woman whose osteoporosis had gotten bad enough that she was in constant pain in her hips, so she couldn't walk a block. And it's when I finally convinced her to join that gym, and she's in there, I think she's only in there like maybe once or twice a week. And over the course of a year has made a massive difference to her ability to move and stay active, and reduce her pain. So it's, along with all the other things that we can do for people, it seems to me that whether it's doing it because it's strengthening the muscles and or stimulating bone turnover, whatever the case may be, it certainly seems to move the needle. Unfortunately, it requires spending money. It requires taking time out of your day and going and doing something that you might not normally do. It's not the only solution, but it's not, what's interesting about it is it's maybe less intimidating to people than going into a gym and lifting weights.
Yeah. I think that's a great testimonial, and that's a wonderful end of one. Yeah. And I think that's great. And I know we talked also, that's exciting. I think we're also going to get your mom on one of the Osteo-K products as well to give her even more protection, because it's not about just doing one thing.
No, exactly.
It needs to be customized. It needs to be tailored to the individual person, what they're willing and able to do and what they can afford, because not everybody can afford one of those memberships.
100%.
There are lots of things that other people can do. I recently, about a year and a half ago now, discovered P-Volve, which is a new exercise, functional exercise, excuse me, classes that I take. And I never used to enjoy going into classes. But I found it to be a game changer for me as I'm getting older, because it's functional. It's about how you're using the body in real life, which really is what gardening is about and walking is about, right? So all of those things, while you're growing muscle, while you're improving balance, while you're doing the diet, while you're doing the supplements, while you're getting enough sleep, to give you the best possible benefits. And the beautiful thing is, with this approach, with what the research shows actually works, when you are doing them, you're not only helping your bones, but the research is clear with all of these recommendations, you'll be reducing cardiovascular disease risk, dementia risk, diabetes risk, excuse me, all-cause mortality risk, fracture risk, and the list just goes on and on.
Love it. Well, this seems like a reasonable place to bring this to a close. I mean, it's a great conversation. I'm sure we could think of lots of other things to explore and talk about. I mean, I've thought about 3 other things as you were saying that, but I'm going to hold my own counsel for that right now. Why don't we tell people where they can find you and learn more, get their hands on your book, and maybe learn a bit more about the supplements that you've designed specifically to meet the goal, which is reduce the risk of fractures, because that's the end goal. It's not about your DEXA score. It's about how likely are you to break a bone. So if you've taken nothing away from this podcast, take that away. It's not about the test. It's about the outcome.
Yep. It's about maintaining strong bones.
Yeah.
So the best place to find out, excuse me, got a little tickle in my throat.
Yeah, go ahead.
Is on my website, nbihealth.com, nbihealth.com. All the information is there, including the supplements, lots of free articles where you can just search for a term and that'll come up. You search for bone or bone health or cardiovascular, whatever you're interested in. There's tons of articles that I've written. So if you want any of those, the research or those studies, reach out to me. I'm happy to provide any of that data. But it's with your doctors if you'd like as well. The book is there also.
Amazing. Well, thank you again so much, Dr. Neustadt. It's been a fascinating conversation, and I look forward to chatting with you some more sometime.
Thank you. It's been wonderful. I appreciate it.